being conducted in Pakistan are basically tackling those sporadic outbreaks here and there. So that was the initial situation where you can see that Punjab was reporting almost the highest number of cases, followed by Sindh, and then the least were GB and AJK. So what we chose this SEIR model, suspected, was infected, and recovered model, and there were a lot of studies going on at that time. There were modeling being done by the ministry itself, and there were articles in the press which were also looking at. There were a number of institutes in Pakistan, universities, especially the one which deal with, like, for instance, university in economics. They were also doing some modeling, but mostly what they lacked, they didn't include this asymptomatic infection and pre-symptomatic transmission. So we included these two things along with other parameters. And the classic SEIR model assumes that an individual in the population is either susceptible, exposed, infected, or infectious, or recovered and immune. So the model used in the study assumes that the exposed class is asymptomatic and does transmit infection. This is the basic assumption, which gives a lot of, you can say that then the denominator becomes very big when we say that all the exposed can transmit infection. So by putting that in our SEI model, those assumptions, you can see here it was this was almost the peak time, which was June 21, when the solar eclipse was there in Pakistan and all over the world. June 21 was the date when we saw the peak as per our model, and after that it started going declining, and it is at the moment, according to this model, it is declining. So you can see that here we have our how many persons it can infect. So we took 3.2. This is the basic assumption which other researchers they took the R naught, which is as per its base published elsewhere. But we took 3.2 with an assumption that our first two notified cases were from Iran. When the people from Taftan border, they crossed into Iran, from Iran into Pakistan, they came back. And the average R naught for Iran was 3.2, and that was the basis for our model. So it goes up to 100 million. But you see that as soon as, what we did is that one thing that we presented, we analyzed this, and it shows the expected number of susceptible, exposed, infected with no symptoms, infected with mild symptoms, infected with severe symptoms, infected critical, recovered, and the dead. So they are towards the higher side, because it is the worst case scenario where you don't have any intervention. So if from February 26, it's around, you see the peak is around 120 days. And this is the time which was exactly June 21 week. And if you do an intervention, then if had there been an early lockdown for the month of March, then the cases would have gone down from the very early. But when there are lockdowns, there is a consequence of that the peak then ends a little bit later, not that early, that when there is no intervention is there. And from interventions, those are the interventions. I mean the interventions which include, or the non-pharmacological interventions, or NPIs. Initially, the WHO didn't recommend face masking as the one of the interventions because it was assumed that the virus was not airborne, it was only through the droplet infection. But later on, when the countries like Korea, Morocco, Czech Republic, uh, then Lebanon, uh, Japan, these countries, they use combination of interventions, uh, locking down, social distancing, and face masking. So these combination of these interventions, even the New Zealand, controlled the pandemic in the very early stages, in the early days, and brought the graph down, brought this curve down, and the curve for these countries became very, in the very early days, it became flat. Even the Vietnam, they also did the same thing. So, but in Pakistan, it was not the case. In India, it's not the case. In the United States, some of the states they don't use masks, and now they are being hit by the second wave. We'll discuss about this concept of first wave, second wave, and third wave, which actually comes from the 1918 uh, flu pandemic. So next, this graph shows about uh, healthcare capacity of hospital beds in Pakistan. So it clearly surpasses the bed healthcare capacity of hospital beds in Pakistan, with and without intervention. So in Pakistan, the disease started 1 month later than most of the countries now. At that time, seeing the peak of epid curve, because when it came to Pakistan, it started very slow, and people had some weird conceptions, misconceptions that perhaps the people have very good immunity, perhaps they use tea, perhaps they do something else, so they won't get this peak. And there was other because it was slow in the beginning until it became it achieved this momentum in 2020, and then
Hello, is the voice gone bad, Walid?
जी सर मेरे ख्याल में
blind spotting. They
Okay,
call it
good.
blind
Yeah,
spotting.
it does. Ejaz भाई, आवाज आपकी थोड़ी ब्रेक हो गई थी, ये थोड़ा रिपीट कर लें लास्ट
Sorry.
few sentences.
Gigi, sorry. My internet connection is not that good. Sorry for that. The sporadic outbreaks, this refers to a study from Egypt. And they did very good job in defining this in this concept of blind spotting, because when you start getting these sporadic outbreaks, you must have observed in other countries and in Pakistan that uh, areas in when before the peak occurred in Pakistan, we had a lot of these outbreaks, sporadic outbreaks in Karachi, in Lahore, in Islamabad, in Rawalpindi, in Peshawar, all the populated, densely populated areas of Pakistan, even in Multan. Uh, we saw these sporadic outbreaks, and till now, we can see that the smart lockdown or smart strategy focuses on these sporadic outbreaks. But these sporadic outbreaks, they confirm the phenomena of blind spotting, and they happen before a peak happens. So when we look at the international data of COVID pandemic, we can appreciate that wherever in the country, when one, for instance, in the US, if you look at the US data or the Canadian data or other countries, or even Italian and Iranian data. So when an area is the COVID cases, they go down and the curve starts getting flat, and in another area they have these sporadic outbreaks. After some time of those sporadic outbreaks, they get a peak. This is happening in the north of US. It has been happening in Pakistan. So this is the blind spotting, and this gives a clear clear insight that when you start getting this sporadic outbreak, then you are going to get a peak, and something has to be done before that. So that was the time period, but we had exact date was June 21, and we recommended that something need to be done. Health system has to be strong. NPIs as a package need to be implemented so that the burden on health system may not be there. So with that, just this study's introduction, let me pose a few discussion points for our panel and all of our attendants. Just they can ask questions, they can discuss it, but these are some of the points. Those were in my mind, and I was discussing with Dr. Shahid Rafiq as well. That how much, and every country has done this modeling. Japan has did this modeling, although not those many cases happened in Japan. In Pakistan, we have the problem with data. We don't know exactly how many cases are there because we have a limited testing capacity. If we do a serious prevalence survey of whole the country, perhaps then we will be able to identify how many exact number of cases are there. And most of them are asymptomatic, and then the mild cases are there. So what has been the preparedness and response to COVID-19? UK has been criticized for its level of preparedness and response to COVID-19, and so as other countries. There are fears around second and third waves of pandemic. Its potentiality to mutate. It's a very strong association with seasonality and new cluster formation with sporadic outbreaks and the blind spotting. Air travel is there. It's not going to stop. Airlines are operating. Cases from the countries like in which the peak has been late, a month or 2 months late. Now they are exporting and importation of virus in the countries which have already controlled, like Australia and the UK, and Australia a few days ago, and even in the Public Health England, they also mentioned that around in Australia 23%, and in the Public Health England they reported that 50% of their imported cases were from Pakistan. What should be the UN's roles in establishing a new agency? United Nations Department of Preparedness and Response to Pandemic, perhaps, because WHO itself has been overburdened. Some of the guidelines have been late, must have caused, for instance, for the use of masks, and on some of the trials of hydrochloroquine, and recently the steroids, which also need a big, the evidence is small. It's not a very robust evidence, but there are some successes, so people are using those drugs. And hydrochloroquine, we know that the studies published for hydrochloroquine, they were confounded because the patients who were using hydrochloroquine, they were also using steroids, so they were confounded studies, but they were published and they were propagated, and the trials were, so much money was put in one single trial to carry forward. So these are some of the discussion points, and I just wanted to share some of our work and put forth these discussion points for all of you. Thank you very much. Hello.
Thank you, Dr. Ejaz. This was an excellent presentation.
Yeah, Iqbal, sorry, I was going to introduce you. I'm getting some calls. So, Dr. Ejaz, thank you very much for this great presentation. I will introduce my friend, Professor Iqbal from Dallas, and he will introduce the rest of the panelists and moderate, because I'm getting some call, but I want to attend it. It's such an interesting topic that you have presented, and I'm sure there'll be a very hearted and great discussion on it. Iqbal, please take it from here and introduce yourself and another panelist.
Thank you, Shahid. Dr. Ejaz, Assalamu alaikum. And
Walaikum assalam, sir. Assalamu alaikum. Very nice.
everybody. We really appreciate your sharing this information with us. I would like to introduce the other panelists. In fact, I'll invite them to introduce themselves. So starting with Professor Amir Khan, if you could unmute yourself. Let me see if I can. Walid, if you can please unmute Dr. Amir Khan.
Assalamu alaikum. My name is Professor Amir Ghafoor Khan. I am one of the professors at Lady Reading Hospital, Peshawar. So we've had the largest burden of COVID patients in KP. And our catchment area population is about 22 million because we take in comers from neighboring country, Afghanistan also. So we've had a good share of our, COVID patients, and let's see what you folks have to say, and I'll interject in between if you want it.
Thank you very much. Dr. Farhan Qadir.
Just Assalamu alaikum ji. I'm one of the nephrologists and critical care. I just finished my fellowship and right now working as a critical care attending in New Jersey. Looking forward to talk to you guys. Thank you very much. Assalamu alaikum.
Thank you, Dr. Farhan. Dr. Kaleem Ahmed. Dr. Kaleem Ahmed, can you unmute yourself and please give us an introduction?
Assalamu alaikum. My name is Kaleem Ahmed. I'm one of the pulmonary critical care and sleep specialists. I am practicing in Hagerstown, Maryland. Thank you.
Dr. Kaleem, Dr. Nigat Ahmed is here. Can we unmute her, please?
Assalamu alaikum ji. I am a fan of Apna's initiative. मेरी खुद भी बड़ी learning हुई है. I am a chair of rheumatology and professor of rheumatology in National Hospital and Medical Center, and I'm also chair of rheumatology in College of Physicians and Surgeons, Pakistan. So we know that most of the things are rotating around rheumatology. So अब देखते हैं आगे क्या होता है with so many trials going on.
Thank you, Dr. Nigat. We're very happy to hear that you are finding this useful. Hopefully other colleagues as well. It's really gratifying to hear that, and welcome. Thank you for your presence here. Dr. Rizwan Taj, Professor Rizwan Taj, please unmute and introduce yourself. Mr. Walid, can you please unmute Professor Rizwan Taj?
I think they are not online.
Thank you. Thank you.
Okay.
Thank you. I'm Professor Rizwan Taj. I'm Professor of Psychiatry and Principal of Federal Medical College at PIMS. We are looking at the mental health part of the national program, and we are continuing with mainly looking after frontline healthcare workers. And at the moment, I'm also coordinating with all the provinces to help establish helplines and stress management sessions for frontline healthcare workers. And we're doing very well, and we've got a system where WHO has given us a lot of information, and we are constantly updating it according to our circumstances and need. Thank you.
Thank you, Professor Rizwan. As you all know, he's been very active in our webinars and panels on support for the frontline staff and other issues dealing with COVID. So I appreciate that we all do. And we also have Professor Arif Harakar.
Yes.
Sarkar, if you could please unmute and introduce yourself.
Hello, can you hear me?
Yes, loud and clear, sir.
Yeah, thank you. My name is Professor Arif Harekar. I'm a neurologist, basically, professor of neurology, and I've been teaching at the Biomedical University for the last 10 years as a professor, and before that, 25 years at Dow University of Health Sciences. So, of course, I have no direct contact with the COVID patients, but otherwise, we've had the patients who have come to us and have been found positive, and then we have sent them to different hospitals who are actually dealing with them. And all I'm going to say is, the session, I partly attended the session. The important thing about the sporadic areas and the resurgence, which might happen, of course, as we look into it. So I think it's very, very important for us to discuss what more we can do. We're based in Pakistan. Thank you.
Thank you, Professor Saab. So I'll start the question and answer session, and you can certainly raise your hand, but also there's a Q&A option. If you could please put your questions in there, not in the chat, because it's easier to follow and respond to. So let me start the question and answer session by asking Professor Ejaz, Dr. Ejaz, how well has your SEIR model predicted what actually happened on the ground? So if you can go back to your, if it's possible for you to go back to your slide with the model prediction peak at June 21st, and now we're on July 5th. How has that model predicted, and how have you adjusted your model? What is the ongoing prediction with the current state of public health interventions? Thank you.
Yeah, thank you very much. There was one question by Dr. Abid, that if the solar eclipse had to do something with the peak, no, it was just a coincidence. It has nothing to do with the peak, just for fun. You can see that without intervention.
Dr. Ejaz, may I ask you to put your slides on presentation mode, so they'll be a little more larger and clearer to see for the audience.
Okay.
So if you click on the screen emblem at the bottom, then thank you.
It's okay?
Yes, that's much better. Thank you.
Right. So if you look at it, at the moment, what the data is showing in Pakistan, that the cases have a downward trend, it goes with the model. Of course, it is quite exaggerated if you look at the number of cases, with around 1 million. They go up to suspected cases go up to 100 million, and because they also include asymptomatic and the mild cases. So actually, we don't know how many asymptomatic are there, because we don't have a very good, very large number of, you can say, the tests being performed is just 25,000 tests with our limited capacity, whatever we have in our country. So the suspected cases from 100 million after June 15 to 21 week, it started going down, and you can appreciate that the recovered ones here, they at this time of point, they have started going down, and the recovered, they have started going up. So at today, according to as we look at Pakistan's reported data or the official data, when we look at data, whatever the sample size is there, it's a very small sample size as compared to the predicted model. But you see, when the recovered cases, they started going up, the suspected started going down, and so will be the infected, critical, and severe infected, and the deaths. That is what is happening at the moment. So we can say that in that sense, although our predictive model is quite exaggerated, but it is, and the current reported pattern follows the same. They are following the same path, and this is the time period around. It becomes around August 15 to August 22 week, when perhaps, or beyond that, in September, early September, we are going to see the flattening, a very slow flattening of the curve. So those cases would be there. And as the Professor Arif was mentioning very rightly, that you have to be careful about these sporadic cases and the surge of the virus, because it will come up. And most important thing for Pakistan at the moment is the coming up the Eid al-Duha, which of course will allow people to go out and gather and with very little social distancing and using the mask. At the moment, when we go out here at this time, when there is a general understanding that the cases are going down, we see very few people using proper masking and observing social distancing. It's almost normal. It happened during the Eid al-Fitr, when the Supreme Court also allowed the big businesses to open and the people start going there, and then we saw a surge, the sporadic outbreaks and the surge, because this trend was going on. But between that, when there are no interventions, then these surges they happen. The sporadic cases they start happening. So they will again happen. And the biggest threat is this, that according to the Institute of Health Metric and Evaluation, I attended their webinar a couple of weeks ago, and their latest model shows that very strong association of COVID with seasonality. So when in winter, all over the world, there is high chance of resurgence or surging of the virus, when the influenza virus will also be there. COVID will also be behaving strangely, very strangely, and causing second or third wave. Thank you.
Thank you. I just want to clarify one thing. If I look at where the curve of mortality flattens out is about 140 days from the start. I'm looking at the gray line, and it's corresponds to the 1 million mark. So is that the predicted mortality from your model for the country?
Yes, yes. It's around 760. So that's the 763,000, the exact number. Which when we in visualization, when we bring our marker over it in the visualization tool, it shows, because these are pictures from the visualization. So exactly 763,000, but of course it's exaggerated, and the hospitals, they have not reported that much. The reported deaths are around near to 5,000. But this, of course, it's an estimate. It's not the exact. So through this model, it shows that these many deaths may happen.
So it's certainly a sobering data. Let me get other people to questions answered here on the question and answers section, and then we'll come back to a couple of questions that I have for you. One of the questions by Dr. Abid is, how do you distinguish between mild, moderate, and severe and critical cases? How are they estimated by the government or by the public health agency?
Yes, these are according to the WHO definition, and the guidelines given by the ministry. So mild cases are somebody having very light headache, or having low-grade fever for a couple of days with a bit of sore throat, and it's not progressing. And the moderate is like having sore throat and having a bit of high grade fever. Uh, and the swear is like having your oxygen also being compromised, going below 93%, 94, 93% saturation, and you need hospitalization. So these are the differentiating ones for mild, moderate, and the severe cases. So and for and these are the universal kind of things. So in the model, these definitions are given. So that's how they are being estimated. But not everybody is going to have it, and there can be a lot of other factors which protect someone or which can modify, because the model assumes R naught. This is 3.2. It can be like in KP. In KP, the case fatality ratio is about 6, but overall Pakistan is around 2 point and something, and in Punjab perhaps it's more, but in Islamabad and AJK it's around 1 point and something. So then the why mortality in KP is 6. That's that you can ask that question as well. Are the people in KP are having severe infections, or they are not getting the healthcare delivery, healthcare services, or they are reaching the hospitals very late, or KP itself is reporting more accurately than the other provinces, and that so there are many ifs and buts when you look at the reported data, at the modeling, and the mortality rates in different. So, for instance, in Balochistan, it's a very far flung. It has very far flung areas, and the reporting of the normal data is an issue in Balochistan. So how come you will not get the exact picture in Balochistan? So that's the. So,
thank you very much for that answer. Yeah. I have quite a few questions here. First of all, the question, and again from Dr. Abid, is if there is no contact tracing, how you measure exposed cases? So I'm not sure if that is accurate, whether there is no contact tracing, if you could answer that. And how do you measure the exposed cases? Thank you.
It's not the what we have done. It's not based on the real data. It's on assumptions, and it is based on the assumption that Pakistan has an R naught of 3.2, and rest of the assumptions are inbuilt in the model for every country. You just put in how many beds you have, how many hospitals you have, how many ventilators you have, what is your population total, what is your total population. So from that, from R naught, it calculates by itself how many exposed could be there, and out of them, what is the percentage from the, and that is inbuilt from the SARS-CoV model, because when the SARS came, the studies of SARS, and then from the Chinese studies. So that's the that comes from there. What you are asking is about the real-time data in Pakistan for Pakistan. So yes, we haven't published on the real-time data because there are these we didn't have the access to the data. It's and secondly, it's not that comprehensive data. It was not that comprehensive data at that time. And for modeling, it's always good to go for the assumptions, because in disasters, in pandemics, you get accurate data at a very later stage. If you don't have because you see in Pakistan, we don't have our hospitals do not report by cause of death. So and we have a very we don't have any accurate data reporting system. There are a lot of room for improvement in Pakistan. So we didn't want to do that, to use that data, which could give us very which couldn't actually give us the right kind of answer. So we use the assumptions which are normally used by statisticians and epidemiologists all over the world.
So I have a live question from Dr. Nuzhat Ashai, who raised her hand earlier. Let me just find her and unmute. I can find. So Dr. Ashai, you're.
Yes. Yeah, hi. Assalamu alaikum. This is Dr. Nuzhat Ashai. I'm one of the Cleveland Clinic nephrologists. I have two questions. One is that the predictive models here usually look at what percentage of social distancing and how it will impact the number of people infected. So that's all, again, not real-time data, that's predictive models. Have we done something like that for Pakistan? I know it would be hard, but again, these are assumptions. So that actually, when that data is presented to the population at large, we have noticed that more people are following the guidelines for wearing masks because they realize that if the percentage of social distancing is observed by 40% as opposed to 20%, what is the impact on the total number of cases? Is there any parallel like that in Pakistan? And secondly, is there a protocol now for how patients are treated when they present with COVID, which is standardized for most hospitals, at least big hospitals in Pakistan, because that might explain how the treatment is offered to patients when they do present. Thank you so much.
Thank you very much, Dr. Nazir. What you are talking about for your first question is the real-time R, which is known as RT. That's something that you monitor the intervention and you find out whether there is compliance up to 40%, 20%, and then you predict whether it's going to be flat or that that intervention could be relaxed or it has to be augmented with some other intervention. No, not at the moment. There is one thing that they are using artificial intelligence to track and find out and actually trace the outbreak and then do the smart lockdown. That is something being done. But what you're talking about, the RT, I have no knowledge about that at the moment, but smart lockdown is based on artificial intelligence and machine learning. Second question is about the protocols. The Ministry of Health has already published a lot of guidelines for patient treatment for public health as well as for the clinical side. And at the moment, my own university, Health Services Academy, along with the hospitals like Dr. Rizwan Taj from PIMS and University of Health Sciences and the Armed Forces universities and other universities of the provinces, they are conducting ICU and the frontline workers training and the training for the ICU and the COVID ward frontline workers training. So there are a number of, I think almost, there is a plan to train more than 100,000 workers of different cadres on the protocols.
So one interesting point that Dr. Ashai raised, and I just want to follow up on that, Ejaz Sahab, is that if this data, very frightening data, if you look at it, predictive model, is shared with the population, and they're somehow by mass media or educational programs, they're told that if they follow the social distancing and the public health interventions, then the curve will go like this. If they follow, if the compliance is so much, the curve will be affected really by their choices. Will that make a difference? No, I'm not sure if that has been. It certainly is communicated to various populations in the developing world and everywhere, and has had an impact. But is there any such program in Pakistan?
Good question. Very good question. I have experience of dealing with 3 disasters in Pakistan, starting from the earthquake, then the cyclone Yamjeen, and then the earthquake of Balochistan. So these 3 main disasters happened, and I had the experience to lead from the health side. And it's very right that when you, from the very beginning, you take the you take community in your confidence and let them know the real situation, then their compliance is very good. and they go along with you. They do all whatever you say. Most around 70% they start complying because I can give you one example that people in Pakistan, and this is published one, that people in Pakistan, they consider polio as no threat, and the parents and the same parents, they consider measles a big threat because they see their children dying that die if they get measles, but they know that with polio they don't die, so they don't take care of polio, but they are very much sensitive about measles, and they go for the healthcare facility to get their child vaccinated if there is a measles outbreak. So this is the common attitude and the behavior of human behavior. It's an aspect of human behavior. Of course, if the people are told that this is the gravity, and if you do such things, it won't. It will go down. However, uh, it mostly depends. It also depends upon how people perceive that threat. That's another important thing, that people have the fear. The general population, they do have the fear, and there have been some CAP surveys recently done by Ahmad University, and there was some other surveys as well. So there is a good proportion of people which think that the COVID has a real threat for them. But when they are asked about using interventions like social distancing or wearing masks or uh, and doing other measures, only 10% they do. So what they fear and what they do, it's a bit different. So I think when from the government side, if the people are not being somehow, if they have the impression that now the things have eased, then they become very relaxed. And that's what my personal observation in Islamabad is this, that the people are feeling very relaxed. And with upcoming Eid al-Duha, I think that's not a good sign. And we might see a huge surge of cases after Eid al-Duha, 2 weeks after that. Yes.
Well, I am sitting here in the great state of Texas, and I can tell you that relaxation is costing our state dearly with the highest spike of cases. So I hope Pakistan learns from that. I'll move on to some other questions. Dr. Sayyid Mohammed Tayyib asks, COVID-19 rehabilitated patients, will they face any permanent side effects regarding lung infections? Would that be a question for you or perhaps one of the panelists?
Pulmonologist, not for me.
Okay, we'll move on. We do have a pulmonologist on the panel, and that's at least one of them. So, Dr. Kaleem, do you want to answer that question?
Sure. So, COVID infection, like any other viral infection, especially we know with the flu, this is a spectrum of disease process, and people who get significant amount of the lung damage, there is a potential, majority of them will recover, but there is a potential that some of the part of the lung or a seriously infected patient might develop chronic sequelae of the lung disease, including a different level of lung fibrosis. So yes, there is a potential for that. One thing I want to add, if you allow me, I think during the early discussion, there is a question about how to prevent the spread, and we all are stressing, but I think there is a very important distinction which we have to make. And the distinction is airborne versus droplet precaution. And COVID so far, what we know from all the studies and the guidelines, is still considered mainly infection transmission through the droplet. Now, the airborne thing confuses the whole picture because we know the airborne diseases are like TB, chickenpox, and measles, where these viruses can stay in the air suspended for a long period of time. when the research has done to figure out whether the COVID could be an airborne, the data, which is the one which I remember published on 17th of March in New England Journal of Medicine, they aerosolized the COVID virus in a closed environment, and they found that it can sustain in that environment for about 3 hours. And that is the reason all the guideline which just came that if you are performing an aerosolized procedure, then you have to wear the N95 mask. Otherwise, because of the droplets are big, one does not need N95 all the time, including in the social environment, because the droplet can only goes up to 6 feet and not beyond that, like in airborne diseases. So that's the discussion. Thank you.
Thank you, Kaleem. That's a great point there. I think there's another question by Dr. Fawzia Farooq, whether Pakistan will hit a second wave of pandemic or not with the data available. I think some of that has been answered by Dr. Ejaz before, but I'll ask him again to address this briefly, if he can.
Yes, thank you. Yes, there is a chance. You see, one thing is this, that the IHME models, the latest model, it shows its strong association with seasonality. With the winter season, it's not only for Pakistan, all over the world, it might happen. And then when the influenza will also play in. Secondly, the way people are behaving, and they are not practicing social distancing and other measures, and the attitudes are quite relaxed. So the virus can, and one thing which I also put in my discussion points, that there are number of articles, a few of them were retracted, but a few of them are still under publication, and one or couple of them have been published about the capacity of virus to mutate. So, for instance, in the UK, it has been reported to mutate around in the labs. They found when you do the genomic sequencing. So they found its mutation at the moment. It has also been published. There are at least 3 to 5 mutations or the types of this virus. So its capacity of mutation surprises. So there is always a possibility, and there is a possibility that it might resurge in coming winter. Thank you.
Thank you very much. There is another question about the lower number of COVID cases. This is from Dr. Abdul Sami Khan. Is that related to low number of COVID samples or a sudden drop in reported cases and death? Is it reporting or is it actual reduction?
It is, you see, we are not testing that much. It's 25,000 cases per day. So it's not that much with a population of 220 million. It's not that much. And the other thing is this, that with the time, people have, there was a surge in getting tested, but now people are not going for testing. They are staying home. The families and families, they get infected. They get mild symptoms. They self-isolate themselves. They know it's COVID. Not all of them, they go for testing. Later on, they do go for their IgG assays, but now this because people are not going for much testing. So it doesn't mean that if the reported cases are going down, you see the deaths. Yesterday the deaths were again 93. Reported deaths from the hospitals were 93. So they are swinging between 100 and 150. So and there are the way this, I don't perhaps other panelists can also educate us on this, that not all all of the patients of COVID, they are dying of respiratory failure, or they are going for the low oxygen saturation. There are many of them who die of stroke, who die of heart attack, or die of kidney failure, because it also causes DIC. So the way it attacks the organs, and the way it targets the organs, also underreports many deaths due to COVID, because not all the deaths all the deaths are tested for COVID. Neither they are being X-rayed, or their tests are being taken. And third thing is this, that mostly in Pakistan, they take the throat swab. So in the beginning, until now, I think it varies. The expertise varies from lab to lab, or hospital to hospital, and the way it is being transmitted from one place to the other. So if they are not following the protocols and right technique, then the false negative tests, they go up. Thank you.
Thank you very much. There is a question by Dr. Sadia Khan about what model have you used for this prediction? So I believe you have answered that, but if you could briefly just describe the model that you used for this prediction. Thank you.
Yes, this is for Dr. Sadia. This is the SEIR model. It assumes individual population which would be either susceptible, and we took the whole population as susceptible, exposed, infected, or infectious, or recovered, and immune. So this is the classic. They also use SIR model, in which E is not there, but we have included E at the moment. So our software analyzes this model, and this is the typical SCR model, which is used to predict for infectious diseases how they are going to behave, and how many number of disease and deaths and recovered would be there. So it's a you can say it's a gold standard to model any infectious disease. So that was also used it is universally it is used for modeling COVID as well. Recently, the Cambridge University, they also did SEIR modeling for Pakistan.
Thank you. Last question on the chat box from Dr. Suhail, Rana Suhail is there any way to determine any test, any prediction to determine why some people are affected with severe disease and some are not?
Yeah, very interesting question. Very interesting question, and people are get intrigued of this, that some of the old people, because at the beginning it was thought that the mortality among the old would be higher, and it was. But then, for instance, in Pakistan, when you look at the reported data, most of the people which are between the age of 37 to 55, the deaths are more among them than the older people. So I think still it's a gray area for research. Why someone is affected more and someone gets mild disease, someone gets severe disease? What is the reason behind? You see, if you look at the healthcare professional data, so the more they are exposed to the COVID patients, the severer is the disease. But again, it has a lot of other factors which might be affecting the common, just an observation. So it is still not that clear. It needs research, because you see, if in my discussion points, so these discussion points which I placed here, they are actually, and of course what you have asked, they're all questions open for further research.
Dr. Kaleem has a question.
Yes, please. Yes, Dr. Kaleem.
So want to know is, we have been in touch with a lot of our friends and family in Pakistan, and I don't know if it's true or not, but look like people are very reluctant if they have either very minimum symptom to get tested. I want to ask you, is there any kind of national or regional policy which is discouraging them because of the fear of forced quarantine or something like that? Or what is the reason? What is the true status of this issue? Why people are reluctant? It's not the money, which I can understand by talking to different people.
Yeah, very right, very correct observation. In the beginning, there was forced quarantine in the very beginning of the pandemic, and that created a lot of trouble. And later on, they just, like in Punjab, it became a huge problem for people whoever was tested positive. Then the police used to come to his or her house and took them away, and then there was a fear then he or she is not going to come back, and he will be buried and something like that. And a lot of wrong information was also there. A number of foolish kind of things that the doctor, they are killing the patients and something like that. So there were a lot of myths and wrong information going on in the media and all those things. But I think that later on, when it became a local transmission in Pakistan. So on the media, the health professionals, they were also advocating this thing that there is perhaps now no need of going for a test. If you have some symptoms, just quarantine, self-isolate yourself in your house, have contact your family medicine specialist online or your doctor online, and just take medicines and keep away to the self-isolation. And when you are cured after 14 days, get yourself tested for IgG and something like that. So most of the people, I think, they are following those non-government, you can say, guidelines. So that might have have brought this testing thing lower than what should be expected.
And the follow-up of that is this the capacity building for the testing? What is the status of that in Pakistan? Because I know in the US we have struggled with this for a long time.
Yeah. They are conducting trainings. The NCOC, Command and Coordination Center, the NDMA, and I think the Asian Development Bank, they are combinedly planned these trainings. So some of them are being done, and there is a TTQ training is coming up, I think, very soon, which will train in this area a lot of health professionals.
Thank you.
Iqbal, can I interject in about this testing thing?
Absolutely, sir.
So you see, obviously there are various factors. One of the big factors is the machines. So you see the PCR machine, which is standard used, is made by Roche. So Roche can produce 40 machines a month. Obviously, you guys in the United States have the preference. So they have about 4,000 orders waiting for the machines. I think it's called Roche Cobas 6,800 or something. So obviously, it's difficult for a country like Pakistan to acquire these machines and build these labs. What the NDMA has done is through WHO that it does acquire some limited number of machines which it distributes province-wise. So like KP would get 5 machines and Punjab would get 6. So the capacity building is taking a lot of time. The antibody testing has picked up a bit more, and I suppose, it's sensible because the PCR ideally you require what we call BSL-3 lab, which is a bit expensive to make. BSL-2 would do, but most peripheral hospitals, what we call district hospitals, don't have those facilities. So in fact, if you were to conduct tests in a district hospital, you do more harm by the aerosolization of the blood. And, so I think, as Ejaz said, most people are self-isolating. There was a lot of fear about it when it came. Obviously, we didn't know. So there was this fear that the whole street would be closed up and, the police would come. It still happens. We do have lockdown, but I think people have come to terms with it by and large. And that's why you see, even in medical professionals, that there is less fear about this. We in KP, especially my hospital, has dealt with a lot of terrorist, activity in the past. So we would have a bomb blast and we'd get about 400 patients brought in one go, like if you remember that children tragedy. But in this case, you see, obviously the doctors were at tremendous risk and are at tremendous risk. So there was a bit of fear, but that has by and large disappeared now. So I think my own feeling is that we are not seeing as many cases as we used to.
Thank you for that comment. That's really relevant. Dr. Ejaz, I do have an interest in disaster medicine preparedness. I'm involved with certain organizations here in the United States. And the next question from Dr. Murad Khan is very relevant to that discussion. So, we learn in disaster medicine that all disasters and crises are political events as well as social events. So how can the lessons, this is from Dr. Murad Khan, how can the lessons of the pandemic used to drive health system reforms in Pakistan?
Yeah, interesting, very interesting. And it's a favorite question for a student like me of disaster medicine. So you see, unfortunately, as a nation, we are very weak on learning from the lessons learned. So we don't keep the track of what went wrong and what we should have done. We had earthquake in 2005, and God forbid, if the same scale of earthquake happens today, we are going to respond in the same way, not an advance with a better strategy or in a better way. You see, the health sector gets very meager funding in the budget, so as the education sector. So to prepare a health sector of just as of Pakistan for any untoward disaster, it has to be very resilient. But our health system is not resilient. The basic component of resilience are not there. This pandemic, I think it gives an opportunity to one should look into what went wrong, why we couldn't, where the things were required for improvement, how it should have been dealt in, and if another pandemic comes in, and as all the world is talking about second and third wave, so we should be, I think, better prepared for the second and third wave, and we shouldn't be responding it to as we did for the first wave. But the thing is this, that the countries like US, UK, and most of the developed countries, they were also in great trouble with this pandemic. But the countries like Vietnam, Morocco, New Zealand, they responded very well against this pandemic. So the only thing was what we can see or we can judge just by judging, not the scientific statement, but just by judging, we can say that if the country is mentally prepared to tackle with a pandemic, and they have the processes in place, whether they are robust or not, because Vietnam doesn't have a very good health system, neither has the Morocco, but Czech Republic and New Zealand, they are the high income countries. But what was required to be done, they did it. Like Vietnam, they had 320 cases of COVID-19, and with those 320 cases, they just tracked their contacts, they contained them. So did and if I talk about Korea, Korea applied their experience of SARS-CoV of 2004, and they had the systems built in place for any pandemic. They just applied that, they just triggered it, and they were able to contain pandemic, COVID-19's pandemic in their country. But rest of the countries, they were taken by surprise. For Pakistan, I would say that we knew that there were cases in China. We blocked our border with China. We started containing the cases there, but we failed to contain the case at the Taftan border. And the basic principle of pandemic is, because I prepared the pandemic preparedness plan for Pakistan in 2014. The basic principle, the first principle is this, that let not the single case come to your country. If it comes, then it is over. Then you are running after it. And there were a number of blunders made when the people who came from Taftan, they were quarantined, samples were taken, and then they were asked to go to their home, and then they will, and in a normal way, they were told that, okay, we'll inform you what your tests, what your result is. But when they went there, they met hundreds of people. They came to see them. So they already spreaded the virus, and then you can't track every case. So there have been a lot of loopholes, and it's better to sit down, document them, and put the processes in place so that they don't happen again. Thank you.
Thank you. I just wanted to follow up with that question. If there is, and I've heard of the NDMA, but is there established NIMS type of system or incident command system or national incident management system that is uniform and deployed across all the provinces for any kind of disasters or crisis?
After 18th Amendment, the health became the subject became the provincial subject. What I suggested in my pandemic preparedness plan of 2014 was the same structure, which you are talking about, having a uniform system under the federal government, because the concept or assumption is this, that when there is a pandemic, it's a federal subject. So there should be an emergency should have been declared, and a single operating system, a uniform operating system should have been established immediately all over the country, so that the pandemic could be tackled in a much better way, because then the provinces, they do their own thing by themselves. But this is pandemic, is an international issue, so it should have been tackled at the federal level and in the same manner as you have tackled.
If you could share your slide where you shows the health system capacity as a horizontal line, just a question about that. So here I see that the number of, is that per total population, the number of available hospital beds, around 10,000
Yes.
or 15,000?
Yes.
So that is the total hospital beds in the country is about 15,000 for a population of 220 million. Is there been any increase or surge in that capacity by, I believe they were building large shelters with.
Now they're doing, yeah. They built in the provinces as well, and in the federal as well. They have built the new hospitals, the infectious disease hospitals. So in just adjacent to my university, they have built one infectious disease hospital. Similar setup has been built in the KP, and they provided several places. They just converted them into the COVID wards. So that's how they tried to improve the capacity and to tackling with the COVID patients.
So would this line now be a little raised? Where would this be in total at this point?
Yes, it's at the moment it is. You see, in Pakistan, 70% of healthcare system is with you see it's 10,000 because public sector. It doesn't include the private sector. So 70% or 75% is the private sector, which in the beginning until now, they don't take the COVID patient in their hospitals. So and then I think by law lately they were forced and they were asked to take the COVID patients to increase the surge capacity of the health system, because this is the public sector. So if and we had the assumption, we only took the public sector hospitals. The private sector hospitals are not included in these data. So it's only the public sector. So for public sector, it was like this. But when you add more hospitals from the private sectors, because at the moment, private sector hospitals are also taking part in taking care of the COVID patients. So this assumption was for public sector. So you don't see much pressure, because if you remember when the peak occurred, all the hospitals in Sindh, they were overflowing. Even an anesthesiast, he died in the ambulance and he couldn't find a place in the ICU in any hospital, both the public and private hospitals in Karachi. So that system was, even for the private sector, was overwhelmed when we were reaching to the peak. Now we are going down, but now the private sector hospitals are, and you see, now the hospital would be at ease, because as I have in my previous slides, the recovered patients, they are going up. Now we are having more recovered patients than the susceptible, and the infections are going down. So at the moment, the hospitals would start having some ease until they have another surge or other sporadic cases, they start coming in, and then there will be again they will again compromise these hospitals.
I have a question by Dr. Tausif Irfan. Walid, can you unmute Dr. Tausif Irfan? His hand is raised.
Hello. Excuse me. Hello.
Go ahead, please.
Can you hear me? I'm Dr. Tausif. It was more of a comment. That means if it has been highlighted that after the decline in the cases, we are going to have sporadic cases here and there. And that is going to be a red flag sign that will herald the onset of more smaller epidemics. So it is high time that we should plan educating the masses not to relax at all and be on the outlook for sporadic cases when the time comes. And when the impending winters and influenza season approaching, it is going to be even a greater havoc. I hope not. But this is the time to make these deductions and to implement them. Thank you.
Thank you.
Very right, very right. Thank you very much.
Dr. Nuzhat, your hand is raised. Could you please ask your question?
Actually, I did not raise my hand.
Okay. That's all right. If you already, then we have Dr. Muhammad Ayub, who has a question. Dr. Ayub, please go ahead.
I think, Iqbal, can I ask one question to Professor?
Absolutely. Go ahead.
So Dr. Ejaz, excellent discussion. I just have this question that you said that there should be a record for the next disaster. So are you aware of that any institution keeping that, or is your institution should do that, Health Services Academy, or who should do this, and why they're, if they're not doing, why they're not doing?
Yeah, this mandate is of the NDMA. So National Disaster Management Authority, because I'll again go back to earthquake of 2005 when I wrote the report on for lessons learned in for the health response during the earthquake, and I submitted it to the then FRC. It used to be Federal Relief Commission. Later, it became the National Disaster Management Authority. But that report, in which all the lessons were there, it never came out of the organization. It was not published, or it was not consulted for other. I don't know. I don't have the knowledge that it is still there or it has been used. So, as a nation, I think we are very weak on keeping the records and learning from them. Basically, if you ask who should be doing this, I think the NDMA should be doing this.
Dr. Ejaz, I would love to see your report for about a 2005. If you still have access to it, would you be able to share it, or is it confidential?
No,
purely for academic purposes as part
yeah. Since 2005, I changed so many computers. And it used to be in my old computer, and I don't have the soft copy at the moment. But I think it was in the record of the Ministry of Health, and then the Ministry of Health got devolved in 2010-11. I'll try to look in my archives in my office, and I'll try to dig it out if it is still there in any folder or file. And if I find it, I'll scan it and send it to you.
Absolutely.
Send me your
Really
email
appreciate
address.
it. So I think we're coming up to, actually, we've gone over this. We've only talked about one disaster. Unfortunately, our country, motherland, is susceptible to a lot of different natural and man-made crises, health related to health. And I think this emphasizes the role of public health and how a robust public health system can help minimize or mitigate the damage from a crisis like this. So, we had a great discussion yesterday about family medicine and a public health response and a system. So this really dovetails to that. I appreciate Dr. Ejaz and his colleagues for educating us on this really important issue, and all the panelists who generously gave their time and expertise, all the attendees who have been extremely engaged and had great questions. Hopefully, we have given them ample time to get their answers. And of course, there are more questions at the end, which we'll pursue. So I will let Dr. Shahid Rafiq close out the session, and thank you, everybody. Dr. Shahid?
Sir, I think they left. So Dr. Shahid left.
Well, I'm extremely grateful to Apna for giving me this opportunity to share my work, and I'm very excited and joyful and very encouraged with the way the discussion has been done. A lot of questions, a lot of very good questions, and a very good discussion. I'm really grateful to Apna Merit, and it was a wonderful experience. Thank you very much.
Thank you very much, everybody. Thank you, Dr. Ejaz, again, and to everybody for their attendance. Appreciate it. And thank you, Waleed, for making this happen. And have a good evening in Pakistan and good rest of the day in other parts of the world. Thank you, and Assalamu alaikum.
Thank you.
Thank you.